Good afternoon, everybody. So cardiac amyloidosis, when a patient comes to us, there are two possible situations. One is a patient comes to us as a cardiologist and we diagnose cardiac amyloidosis. And secondly, amyloidosis has already been diagnosed and the patient is referred to us to find out whether there is a cardiac involvement or not. So the commonest amyloidosis that we actually encounter is a AL amyloidosis. And of course, ATTR amyloidosis is being increasingly diagnosed, at least in the West. We have carried out evaluated a number of patients with heart failure, preserved ejection fraction, and the high-risk group. We have found very small numbers of ATTR amyloidosis. So cardiac amyloidosis in AL amyloidosis is very common. It's around 50 to 70% of all patients with AL amyloidosis will have a cardiac involvement. And this is the main determinant of prognosis. The other common organ involved is the kidney, and cardiorenal involvement of both heart and kidneys is around 40% of individuals. So, clinical manifestations are, of course, there raccoon's eye, that is papules which have ecchymosis. We have macroglossia, and a typical ECG that shows low voltages in the limb leads and preserved voltages in the chest leads. These are typical of amyloidosis. But the challenge is to diagnose the patient early. Once the disease is advanced, then the prognosis is poor despite the treatment. So what is the ECG criteria, the ESC criteria on echocardiography? So the first thing is that the LV wall thickness is increased. And this is usually mild to moderate, but occasionally there can be severe left ventricular hypertrophy. In addition to wall thickness, either there is evidence of diastolic dysfunction or there is a multi-parametric echocardiography score which basically looks again at diastolic dysfunctions, RV function and the longitudinal strain. So this is a typical features of a cardiac amyloidosis. And the basic aim is we must diagnose it before this stage is reached. So even if this patient is treated, the outcome is going to be poor. So we can see the typical features. There's left ventricular hypertrophy. Despite the hypertrophy, the contractility is not very good. Features of restrictive physiology, that is biatrial enlargement is present. And as we can see that the interatrial septum is also thick. Occasionally, there might be some pericardial effusion. Left ventricular outflow tract obstruction is not present in cardiac amyloidosis. I've just seen one patient with amyloidosis who had a left ventricular outflow tract obstruction. This patient had associated hypertension. Otherwise, because the left ventricular dysfunction is there, the systolic function is not very brisk. So outflow tract obstruction is extremely rare or almost non-existent in patients with cardiac amyloidosis. So ventricular hypertrophy is usually biventricular. The left ventricle and right ventricular both are involved. It is often symmetrical. Diastolic dysfunction is prominent. So you get typical biatrial enlargement. Mild pericardial effusions may be seen. This is typically if there's right ventricular dysfunction, some valvular thickening. Granular sparkling appearance is a non-specific finding. And we must know that this is not to be commented on if we are using harmonic imaging that we normally do in our setting. So there is usually mild left ventricular systolic dysfunction initially. Later, the left ventricular dysfunction becomes severe. And of course, there is reduced global longitudinal strain with apical sparing. So we can see that the apex is contracting relatively better as compared to the rest of the left ventricle. MRI is also a useful imaging modality. In our center, usually we insist on a tissue diagnosis. So either we do an endomyocardial biopsy or a FNAC from the abdominal fat pad or a kidney biopsy. Some centers are treating even amyloid even based on a cardiac MRI imaging. But in our center, we insist on a tissue diagnosis. So the characteristic MRI findings are diffuse subendocardial or transmural late gadolinium enhancement, abnormal gadolinium kinetics, and increased extracellular volume. So this is typical. We can see right ventricular hypertrophy as well as left ventricular hypertrophy, and there is a pleural effusion. And we can clearly see that there's subendocardial enhancement and there are areas of transmural enhancement. So late gadolinium enhancement has a sensitivity of 85% and a specificity of 90% in a given clinical situation. Initially, it is subendocardial and later it is transmural pattern. T1 mapping is also useful. So the differential diagnosis, as we can see, is endomyocardial fibrosis. This is another cause of restrictive cardiomyopathy, and at least in the initial stages of where we have a diffuse inflammation, this can sometimes resemble amyloidosis. Later stages, of course, the differential diagnosis is not very difficult. There we can see on the left-hand side that typical fibrosis has already occurred. And here we can see that the RV apex is obliterated in the lower image. The other differential diagnosis is hypertrophic cardiomyopathy or idiopathic restrictive cardiomyopathy, which is probably the commonest cause of restrictive cardiomyopathy in India. So all restrictive cardiomyopathies have typical biatrial enlargement, and this is due to a sarcomeric gene mutation. So ATTR is basically a pre-albumin that is deposited. It is synthesized in the liver. It may be either a wild type, which occurs in the elderly around the age of 75 to 80, or it may be mutant, which can occur in younger individuals. It causes heart failure. So ATTR amyloidosis is typically seen in two situations: heart failure with preserved ejection fraction, especially younger individuals, and patients with severe aortic stenosis. So wild type, later age, whereas the variant or the mutant occurs at a young age. There are two manifestations of ATTR amyloidosis. One is heart failure with preserved ejection fraction, and the second is neuropathy. So patient may present with both or each one's individually. Atrial fibrillation is common in this condition. So ATTR amyloidosis, at our place, we are diagnosing the initial investigation of choice is a scintigraphy using a biphosphate. So this is usually used for a bone scan. So this is the initial investigation of choice. If this is normal, we can exclude ATTR amyloidosis. If this is positive, it may or may not be ATTR amyloidosis. It may be ATTR amyloidosis or AL amyloidosis. So a positive scan with negative serum free light chain assays indicates that this is a ATTR amyloidosis, and we need not do any investigation further. We must exclude AL amyloidosis because some uptake occurs in patients with AL amyloidosis around 50% of individuals. In around 20% of individuals, this is significant uptake, around grade 2 to grade 3. So a positive biphosphate scan with negative light chains is a diagnosis of ATTR amyloidosis. So to summarize, as a cardiologist, as a physician, the aim should be to diagnose AL amyloidosis early. If the diagnosis is delayed by, let us say, 6 months to 1 year or by a few months, then the outcome is very poor. So suspect amyloid and diagnose amyloid early. Thank you very much.